Hello everyone, welcome to my class today on NEET PG 2020 Recall in Surgery Part 2. So this is my second class. I've already taken one class where I've discussed some of the questions. This is my second YouTube class on surgery recall. If I am loud and clear, please wave out to me. I'll just wait for a few seconds and then I will begin. This will be a discussion of the MCQs asked in NEET PG in surgery this year. If I am loud and clear, please wave out to me so that I know you are with me. Hi A1. Let's try to keep this two ways and I expect you guys to interact with me well. All those who are online, please wave out to me. Give me a hi if I am loud and clear. And then I will begin with the class. I'll just wait for a few seconds for everyone to join in and then I will begin. So A1, did you appear for the NEET PG this year or you will be appearing next year? Hello Sonia. Good to see you guys. Did you appear this year for NEET PG Sonia? If any of you appeared, how was your experience? How did you find the questions in surgery overall? I am seeing your comments on my cell phone on the YouTube channel. So please feel free to comment. So how did it go A1? How did you feel it was? How was the surgery part? Was it too difficult or was it attemptable? Hello Dhananjay, thank you for joining. Okay, so all those with me, I will discuss some of the questions. Some I've already discussed in my earlier YouTube class as well as on my special classes at the Unacademy platform. Everything was good except Gynac and Pharma. Lengthy paper. Okay. Yeah, Gynac, I saw the questions. They were a little tricky. Paper was lengthy. If you could not find out the key points, it could take you a lot of time to crack the questions. I understand that. Okay, only two wrong in surgery. Let's see some of which will be discussed today, I guess. Okay, so I will begin the class now. I am Dr. Amrit Nasta. I am a bariatric surgeon from Mumbai. I am an educator at the Unacademy platform. So this was one of the questions. 45-year-old male is incidentally diagnosed with a 5 centimeter abdominal aortic aneurysm. What is the expected management? Is it an endovascular aneurysm repair? Wait till it becomes 5.5 centimeters, then do the repair. Wait till it becomes 7 centimeters, then do the repair, or open surgery and repair. What is the answer, guys? Okay, A1 is saying wait till it becomes 5.5 centimeters. Anyone with a different answer? Sonia, Dhananjay? Anyone with a different answer? Dharmendra Sisodia, yes, you guys are right. Wait till it becomes 5.5 centimeters. So there were a lot of questions asked on PVT and abdominal aneurysm. Now, obviously, they will not repeat the same question. So why is it 55 millimeters or 5.5 centimeters? Why not operate before that? That is because below 55 millimeters, the chances of rupture are very low. the chances of rupture are very low. Only above, yes, Sonia, that's right, only above 55 millimeters, the chances of rupture become high. Alright, now I will answer that question. So, screening for abdominal aortic aneurysm is ultrasound after the age of 65 years. Okay, and it is called an abdominal aortic aneurysm only if it is more than 3 centimeters diameter in males or 2.5 centimeters diameter in females. If it's less than that, it is not called an abdominal aortic aneurysm. Now, as I said, risk of rupture increases after it crosses 55 millimeters in both males and females. Below 55, periodic surveillance. Your question was, what if he comes with pain in abdomen? Remember, any aneurysm which is symptomatic, you will always do a repair, irrespective of the size. Irrespective of size, if it is symptomatic, so if he has pain, you have to repair. So if in the original question there was the patient has pain or some symptom, then the answer becomes EVAR. Then this becomes the answer, irrespective of size. I believe they had not posted any symptom. He was asymptomatic incidental, so the answer becomes 5.5 centimeters. For popliteal aneurysm, which is the most common peripheral aneurysm, popliteal aneurysm, which is the most common peripheral aneurysm, repair if it is more than 20 millimeters. Okay, repair if it is more than 20 millimeters or 2 centimeters. Alright, so remember symptomatic aneurysms, irrespective of size, please answer will be repair. Commonly done repair is EVAR, that is endovascular aneurysm repair. This is your next question. Patient came to ER with polytrauma. Which of these is not a component of primary survey? Not a component of primary survey. Measuring blood pressure, removal of clothes, CT scan, or asking him to speak. If the question is a little different, okay, it's because I have gotten these questions from recall. If it's a little inaccurate, please correct me so that even I can improvise upon it. But this is the closest I have gotten. So A1 says C, Ali Abbas Saeed says C, CT scan. Dharmendra says CT scan. Indrani, who has also come from my previous classes. Hi Indrani. Yes, he also says CT scan. So all of you got this right. CT scan is the correct answer. Dhananjay, yes, CT scan is the correct answer. This was one of the easier trauma questions. Now you all know what is primary survey. Now something new that is added in primary survey is this small c. Conventionally, primary survey was believed to be ABCD, where A was airway. Now the Billion Love states that even before you look for airway, you are supposed to do what is small c, that is control of exsanguinating hemorrhage. Okay, control of exsanguinating hemorrhage. Remember this, even before airway, answer will be control of exsanguinating hemorrhage. Alright. Yeah, Dharmendra, please rectify the question if it is not fully accurate. Hi, Janvi Bajaj. And if this small c is not given in the option, then the next best answer obviously is going to be airway with cervical immobilization. Now remember, if both are given, if one option is airway and one option is cervical immobilization, then the first thing you will do will be cervical immobilization. Okay, cervical immobilization comes before airway. And obviously, the small c, that is control of exsanguinating hemorrhage, comes even before. So this will be the first answer. Then B for breathing. Now, in circulation, these are some things that I've gotten from Bailey and Love. Remember that in circulation, you take two large bore IV lines. You all know that. And the target blood pressure should be between 70 to 90 mm of Hg systolic. Alright, this is the target blood pressure, not more than this, because if you increase the blood pressure more, then the person will correspondingly bleed more. Okay, unless he has a head injury wherein your target blood pressure will be more than 90 millimeters of mercury. Only in head injury, your target systolic blood pressure should be more than 90 millimeters of mercury, for the simple reason that the cerebral perfusion pressure is the mean arterial pressure minus the intracranial pressure. So I have to keep the mean arterial pressure in so that the brain gets enough perfusion. Alright, now an important point about circulation with fluid resuscitation in polytrauma. So if they ask you fluid of choice for resuscitation, the first answer in polytrauma, in the fluid of choice of resuscitation will be 250 ml O negative blood. Okay, this is from Bailey and Love. So this is the new guideline. Fluid of resuscitation in polytrauma, or the first fluid that you will give will be O negative blood. Okay, so they say blood for blood. If this is not available, then the next best option will be normal saline. Okay, the next best option will be normal saline. Please remember this. This is something new. It is there in Bailey and Love. And the ratios of packed RBC to FFP to platelet transfusion is 1 is to 1 is to 1. All this is for MCQ. 1 is to 1 is to 1. And there is something new, that is tranexamic acid. You know that is a coagulant. It promotes coagulation. It promotes clotting. This tranexamic acid has to be used in all patients with hemorrhage who have a systolic blood pressure of less than 110 or a pulse of more than 110 within 3 hours. Alright, if the patient has hemorrhage or trauma, use tranexamic acid within 3 hours. This is again a new guideline which was not mentioned earlier. This was an interesting image based question. So they had given an image similar with a swelling in one of the limbs, and they had said the swelling does not put on pressure. What is the reason for the swelling? Is it an arterial block? Yes, Janvi, it's an antifibrinolytic. Thank you. So is it an arterial block, venous insufficiency, lymphatic block, or fatty deposition? What is the swelling? They had given a similar swelling. Alright. A1 says C, lymphatic block. It doesn't put on pressure. Ali Abbas Saeed also says lymphatic block. Okay. Why not venous insufficiency? You get edema, venous edema. What is the giveaway? Why is it not venous insufficiency? Why is it not fatty deposition? Janvi Bajaj also says C. Sisodia says C. Anybody for fatty deposition? Does fat put on pressure? Sonia also says C. The key part is doesn't put on pressure. Non-pitting. Okay. Most of you are right. Yes. The answer is lymphatic block. The image was an image of lymphedema. Yes, Dhananjay, you are right. This was the image of lymphedema that was non-pitting. No, Janvi, lipedema or fatty deposition will also be non-pitting, as I will show you. Now you know arterial block will never present with edema. If it is venous insufficiency, the person should have edema with varicose veins, obviously. Now the only doubt, yes, Dhananjay, venous edema will be pitting. The only doubt was whether it was lymphedema or fatty deposition, which is called as lipidemia or lipedema. Alright, this is something given in Bailey and Love, something which not many of us know. This can be a question in the next exam. It can come in AIMS. Alright, so what is this lipedema or lipoedema or fatty deposition in the limbs? Now this lipidemia, as you can see in this image, is going to be bilateral and symmetrical. Both the limbs will have the fatty deposition. It is usually seen in obese women who have more weight distribution in the lower half of the body. The important thing here is that the feet appear normal. You see the feet over here. The feet are normal in contrast to this, where the feet show some characteristic features like buffalo hump in lymphedema. You get buffalo hump, you get what is called as squaring of toes, right? That is what you see in lymphedema. In lipedemia, the feet are normal and the appearance is what is called as an inverse shouldering. Okay, inverse shouldering. This also is non-pitting type. Okay, so this will also not pit because it is fat, it is not fluid. However, in long run, there are no skin changes that you see in a lymphedema or in a filariasis limb. So, the important thing, bilateral, feet are normal, non-pitting, no skin changes. And if you do an MRI of lipidemia, it will simply show fat accumulation without any edematous fluid. Please remember this. This has not been asked before. It is something new and it can come in your exam. Now, this was a question which a lot of students told me that they got wrong. It was not so tricky. Okay, I have changed it a bit. So there is a patient with dysphagia to liquids. Manometry is done. The findings show absent peristalsis in the body of the esophagus, hypertensive lower esophageal sphincter. Esophageal pressure is more than 450 mm of Hg. What is the diagnosis? Type 1, type 2, type 3 eclasia or jackhammer esophagus. Okay, this is taken directly from a table in Bailey and Love. They asked a lot of scores, a lot of tables, okay, which is what was focused on in surgery this year. So A1 has said type 3 eclasia, Ali Abbas has also said type 3 eclasia. What a lot of my students told me, what they marked was jackhammer esophagus, which unfortunately is wrong. It is not jackhammer esophagus. Anybody can tell me the other name, the commoner name for jackhammer esophagus? A1 or Ali Abbas? Yes. Okay, A1 is now saying, yeah, he marked jackhammer. Unfortunately, a lot of you marked jackhammer. What is the other name for jackhammer esophagus? Anybody? Okay, I'll wait for you to answer that. Meanwhile, what are these types of eclasia? They are based on a classification called as Chicago classification based on manometry. Alright, so manometric classification of eclasia cardia, type 1, type 2, type 3, I will discuss each. In this case, the answer was type 3 eclasia. Okay, type 3 eclasia. Now, why is it type 3 eclasia and why is it not jackhammer esophagus? First of all, in any eclasia, the important finding is absent peristalsis in the body and an increased LES resting pressure. These two manometric findings confirm that it is first of all an eclasia cardia. So when you got these two findings together, jackhammer should have been excluded. Okay, jackhammer should have been excluded. Then the confusion was between type 1, type 2, type 3. Now, what are they? What is the difference between these? Now, in type 1, which is the classic eclasia, it simply shows absent peristalsis. Obviously, this is the most common type. It simply shows absent peristalsis in body, hypertensive LES. Type 2 shows something that is called as an esophageal pressurization. Okay, and type 3 shows esophageal spasms of pressure more than 450 mm of Hg. This was what was given in the question. That is called as the spastic type of eclasia cardia. Alright, this was what was asked. This is from a table in Bailey and Love in the chapter on esophagus, which I have covered in my class. So remember these three types, where type 1 is the most common type. Type 3 shows esophageal spasms, alright, where the pressure is more than 450 mm of Hg. And an important pointer here is for type 3 achalasia, surgery doesn't help. The surgery, that is Heller's myotomy, doesn't help because the spasms are not going to go away. Okay, the spasms are not going to go away with the Heller's cardiomyotomy. So surgery doesn't help much. These are the patients where an endoscopic dilatation is enough. Endoscopic dilatation is enough. You don't need a more long-term surgical treatment. Okay, because the spasms are not going to go. Nutcracker esophagus is the other name of jackhammer esophagus, where the pressures are in excess of 8,000. In the question, it was 450. In jackhammer, the pressures are in excess of 8,000 mm of Hg. This was another easy question. Most common endocrine tumor of pancreas. I hope most of you got this right. Gastronoma, insulinoma, glucagonoma or VIPoma. Okay, this was one of the easier questions from endocrine tumors. A year after year they ask something or the other on endocrine tumors. So these are not the topics you can let go of. So yes, I'm waiting for your answer. Most common endocrine tumor of pancreas for all of those who are online. A1 is saying insulinoma. Anyone with a different answer? Chanakya, Ali Abbas. Yes, all are saying B. Sonia is saying B. Dhananjay is saying B. This was an easy question. Yes, insulinoma is absolutely correct. Now, little bit about endocrine tumors that you must know is that insulinoma, 60% of all endocrine tumors of pancreas are insulinoma. Gastronoma is the second most common. Okay. In men 1 syndrome, gastronoma is the most common pancreatic endocrine tumor. Okay, this has been asked many times. Most common endocrine tumor of pancreas in men 1, it is gastronoma, not insulinoma. And remember, gastronoma shows 100% sensitivity to somatostatin receptor scintigraphy. Somatostatin receptor scintigraphy or SRS, 100% localization of gastronoma. Not so for insulinoma. Now a little bit about insulinoma. It shows that classical Whipple's triad, that is hypoglycemic symptoms on fasting. Okay, sugar less than 50 milligram percent and improvement of symptoms after IV glucose. This is your classical Whipple's triad. Alright. Yes, probably one of the other options was Zollinger-Ellison syndrome. Yeah. Okay. And the diagnosis is elevated fasting insulin and elevated C-peptide. Obviously, C-peptide is one of the breakdown products of insulin. Usually it is benign. Usually medical management with diazoxide is sufficient. If you are doing surgery, then the best way of localizing is intra-op EUS. Endoscopic ultrasound intraoperative is the imaging of choice for localization of insulinoma. And because it is benign, the treatment is an enucleation. You don't have to do a complete pancreatic resection or a radical resection because most of the times they are benign. Friends, endocrine tumors of pancreas, high yield topic. They will ask you something from this year after year in AIMS as well as in PG, NEET PG. This was another important question. Patient undergoing total parathyroidectomy. The biochemical change observed is 50% drop in serum PTH in 5 minutes, 50% drop in 10 minutes, 75% drop in 5 minutes, 75% drop in 10 minutes. The options were something like this. It was all percentage drop and time. Basically, what they were asking you is what is called as the Miami criteria for ensuring that you have removed all the parathyroids. So, what is the Miami criteria in parathyroidectomy? Yes, the options were a little confusing. They just played with numbers, which is the correct answer. I hope you guys got this right. Again, thyroid, endocrine, parathyroid, they are all favorite topics. Dhananjay is saying B, 50% drop in 10 minutes. Anyone with a different answer? Ali Abbas Saeed is also saying B. Anyone with a different answer? Anyone with A? 50% 5 minutes? Not many of you are answering. I guess not many of you attempted this question. Yes, the answer is a 50% drop in PTH level within 10 minutes. This is the Miami criteria for diagnosing that you have removed the parathyroids completely. All four parathyroids have been removed is identified by a 50% drop in PTH compared to the preoperative values. Okay, because a lot of times parathyroid gland looks like fat and you have to remove four of them. So a lot of times you feel you have removed, but actually you've just removed the fat in the neck. And if they are not entirely excised, the person can have a recurrence of the hyperparathyroidism. So the answer is this Miami criteria, 50% drop of pre-op value in 10 minutes. Okay. Now when you have removed all, if you want to reimplant some part, they are reimplanted in the brachioradialis muscle. Again for MCQ, reimplant them in the brachioradialis muscle. If it's a parathyroid adenoma, then you will simply remove the affected parathyroid. That surgery is called minimally invasive parathyroidectomy, wherein just the affected parathyroid is removed. However, in men's syndrome, normally you don't have an adenoma, you have hyperplasia, wherein you do 3.5 parathyroidectomy. Three glands are removed completely, one gland is removed nearly completely, half of it is left behind. No, reimplant in SCM Ali Abbas is only done if they are removed accidentally during thyroid surgery. No. So reimplant them in the SCM only if accidental removal in thyroid surgery. If you are intentionally removing the parathyroids, they are reimplanted in the brachioradialis. This is as per Bailey and Love. Okay. So get that doubt cleared. This SCM is only accidentally removed in thyroid surgeries. There are two phenomena you need to know. Persistent primary hyperparathyroidism is if the hypercalcemia comes back or returns within 6 weeks of surgery. If it appears after 6 months, then it is called as recurrent hyperparathyroidism. Alright, these terminologies are important for MCQ purposes. Okay. Now about localizing the parathyroids preoperatively, this sestamibi scan, this is a scintigraphy. This is the most accurate method. Sestamibi scan, most accurate localization of parathyroid. Something else you can do is a 4D CT, which shows a rapid intake and washout of contrast in the parathyroids. These are non-invasive. Okay, if you are doing an invasive localization, then you can do an angiography or a selective venous sampling. Alright, an angiography of the parathyroid or a selective venous sampling of the parathyroid glands. This is the last question of today. Another simple question: which of these is correct regarding retrosternal goiter? Blood supply usually from mediastinal vessels. True, retrosternal goiters are common, usually excised by cervical approach. Compressive symptoms seen in majority of patients. I have changed the options a bit because I could not get the other options as this was a fairly straightforward question. Which of these is correct regarding retrosternal goiter? Okay, I hope most of you got this right. Please answer this question. The options may be different, the incorrect options, but this was such an easy question that most of you did not have recall of the wrong options. Ali Abbas is saying D. Okay, A1 is saying C. How different was the question? Which of these? It was about retrosternal goiter. Indrani is saying D. If the question is different, then it's good. This is something you can practice. Yes. What is the answer? MRI. Okay, one of the options may be MRI is done in all cases. I have made it more difficult then by putting that. Definitely, that was also not the correct answer. What is the correct answer? The correct answer, yes, Dhananjay, you are right. Usually excised by cervical approach or with from the neck. This was an easy question. I hope most of you got this right. The blood supply is also usually from the neck or the cervical vessels, not mediastinal vessels. True, retrosternal goiters are uncommon. Obviously, they are not common. Compressive symptoms are rarely seen. They are rarely seen. So the answer is usually excised by the cervical approach. Now, there are a lot of things about retrosternal goiter that you must know. The most common type is the substernal type. There is another type which is the plunging type, wherein part of it is in the neck, part of it is in the retrosternal space, and when he swallows, the retrosternal part comes out. That is plunging. And true retrosternal, they represent ectopic thyroids, and they are extremely rare. Okay, compressive symptoms are rarely seen. Pemberton's sign is positive. You know the Pemberton sign. Raise the hands above the head and take a deep breath. There will be congestion of face. Right? I hope you guys have done this in your final MBBS. There is congestion of face due to SVC compression because of a narrowing of thoracic inlet. Blood supply comes from the neck, excise from the neck incision. Important point is right here. When do you need to do a sternotomy in retrosternal goiter? Sternotomy is required if it is malignant or if it's a revision case where there are a lot of adhesions, or if it is extending into the posterior mediastinum, or if its diameter is more than the thoracic inlet. That means if it is bigger than the thoracic inlet, obviously you can't bring it out from the neck. So remember these four scenarios: malignant retrosternal, revision surgery, posterior mediastinal, and diameter of the retrosternal part is more than the thoracic inlet. In these cases, a sternotomy is going to be required to remove the goiter. Alright, friends. So, this was a discussion on some of the questions asked. What you realized was they were not so difficult. They were standard topics. They just tried to trick you and trip you. Okay? And if you fell in the trap, then you got it wrong. Not safe to do an OPD, can cause giddiness, that is rarely ever seen. Okay, so let me tell you what I do at Unacademy. So I cover general surgery. Alright, I have 4 courses that I will be doing, wherein I will cover everything in surgery comprehensively. My first course will be on these topics: breast, thyroid, endocrine, fluid, electrolyte. Each class will be of 1 hour duration. My current course, my ongoing course is GI and HPB. Yesterday I took esophagus, tomorrow I will be taking stomach. And then these are the remaining topics that I will be covering in my second course. My third course will be on trauma and recent advances. So a lot of questions were asked in trauma, so trauma will be comprehensively covered. Energy sources, laparoscopy, robotic surgery will be covered. Instruments, imagings will be covered, and bariatric surgery will be covered. Some of these topics did not feature this time in NEET, but they are expected to be asked. And my fourth course will be super specialty, wherein urology, transplant, plastic, burns, pediatric, and hernia surgery. Lot of new things happening in hernia nowadays. So I will be taking one class on hernia surgery also. So if you attend these four courses in about 20 to 25 hours, surgery will be covered comprehensively. Alright, so if you are planning to appear for May AIMS in the next 2 months, everything in surgery will be covered 1 hour class over 2 months in about 20 to 25 sessions. So if you wish to subscribe, you can use my code. My code is Amrit Nasta. Everything small, you will get a 10% discount. It's not just me. You will have access to all the educators teaching on the NEET PG Unacademy platform. Alright, so you can come for the classes. I will be taking a class on preparation for May AIMS also, Dhananjay. So if you join on the platform, it will be useful, and definitely surgery will be covered comprehensively. And you will have access to a lot of educators, not just me. Alright, so I hope this class was useful. If you liked it, please give a like and a thumbs up, leave your comments, and thank you for joining me. I hope to see you on the Plus platform. Thank you, friends.